Hello, welcome everybody to this presentation here. My name is Russ Eiskis, and I'm one of the leaders of our MedSFLA group here. I just want to say if anybody wants to sign up for our MedSFLA listserv, there's a form right there. Just put your email or over by the pizza. I'm sure you all got that, but the sign-up sheet is over there now. I just wanted to say thank you all for coming, and I'd like to introduce our speaker here. This is Dr. Calhoun, and he's a diplomat of the American Board of Obstetrics and Gynecology. He's board certified OBGYN, subspecialty of maternal fetal medicine. Yeah, he's been a pretty prolific author, great scientist in this field. You know, more than 60 peer-reviewed articles. He's presented over 100 papers and participated in over 40 research projects. So he knows what's going on there in science. And, so one of the other things that he's done is he's published lots of articles on perinatal hospice, which is what he's here to talk about today. So I will let him get forward talking about that. So just like to say, let's all welcome Dr. Calhoun.
You can hear no better. You have a fairly stentorian voice. I appreciate you inviting me here. This is one of my favorite topics is talking about perinatal hospice. I do maternal fetal medicine, so a lot of my work is with patients who have adverse prenatal diagnosis. I do a lot of ultrasound. I do a lot of patients who have a lot of very ill perinates. So this is one of my areas of great interest. We have a freestanding Elizabeth Children's Hospital in Charleston. We're about 350 beds, relatively small. Our whole system has about, oh my goodness, what is that all about? How do we do that? You know you got your viral infections and this stuff to you all the time, don't you? It's like 8 feet. There we go. We have about 850 or 900 beds in another hospital, so all over, probably about 1,200 or 1,300 beds, relatively small system. But we have a freestanding independent hospital for women and children. What I'm going to do for those of you who are like my lovely wife are of German descent, and like Ordnung, as we say, and want to know where we're going to go and how we're going to get there, or the MCD among you. This is what we're going to talk about. We're going to talk a little bit about hospice. I'm going to tell you a little bit about that. We're talking again general hospice concepts that most of you are probably already familiar with. I'm going to give you a definition. I'm going to talk about how we've done it, where I've been. I'm going to give you a couple different results. One in the military, one in the previous life, one in my other time where I was at in the civilian area in Illinois. And I'm going to talk a little bit about programs that are available throughout the country and the world a little bit, and then some challenges regarding perinatal hospice. Well, basically, who cares, right? And that's what I always tell people. I'm very pragmatic. I'm an obstetrician gynecologist, so I'm sort of either pregnant or you're not pregnant, right? So the uterus is not in reach, right? That's sort of cesarean section, vaginal. I'm sort of a digital kind of guy. So why do we need to do this? Well, because if you hold people in this room, almost every one of you would know someone, or be one removed if somebody who's had a child with either an adverse diagnosis or somebody with trisomy 13 or 18 or an MedSFLA or stillbirth. And so it's really important to understand what this, how familiar you're going to be with this, what you take care of in obstetrics for somebody may do, that you won't see this. We're talking a little bit again about maternal hospice. I'm going to talk about perinatal hospice, and I want to talk a little bit about how you might think about doing this or creating your own perinatal hospice if you don't really have one available. I'm also a proud grandfather of 2 children, 2 grandchildren. I will show you pictures because you just don't know who I am, so it's kind of nice to know that I'm just not Dr. Calhoun, I'm actually a grandfather and a father both. This is little Katie, we're at Disney World. We're actually watching Beauty and the Beast. What we're doing. Well, how did this really come about? Well, as we've gone through ultrasound, we've gone through the ability to do prenatal diagnosis. For those of you who are a little more mature, like I am, I see a few more mature faces here in the audience. When we started doing ultrasound, it was the size of a 9-inch television. And you could maybe see ahead of the baby if you're lucky. That's the truth. Now we can do real-time 3D 4D. So what that allowed us to do was to be able to increasingly diagnose prenatal anomalies to much, much higher detail and much, much earlier. And birth defects, still a leading cause of neonatal death in the United States. The incidence of lethal anomalies is about 0.2 to 0.3%. That's down from 0.7 to 0.8, and that's because most babies are now aborted before they're delivered, not live birth. Lethal anomalies are about between 6,000 and 10,000 a year, plus or minus depending on who you talk to and what you describe as a lethal anomaly, right? Well, traditional counseling, this is what I learned, and this is where we started out with all this, was to just basically do a study about termination of pregnancy. I think there were some really good reasons why people did that. One, I think, people thought we were going to spare these moms and families a distressing experience and we would, get this over with. Right? I think also because I'm a surgeon, as an obstetrician, I still operate with residents, I still do a lot of surgery. You're a surgeon, you want to do something, right? Surgeons do things, right? I think it's also we thought we were going to prevent maternal and complications of childbirth, and we also thought there would be an increased risk for maternal mortality. And so those are all really relatively good and reasonable things to think about. Unfortunately, there's no data, right? Well, this is my mother. I call her the stern lady. And I would like to show her because she's now 95, not 93, and she still is a stern lady. My mother was Maggie Thatcher. Okay? So if you think about older people that you know, like my mother who's 95, there's still a lot of them that reading LA Times Cross. How many people here read the LA Times Crossword puzzle? One, and you're a lot younger than my mother. My mother does the LA Times Crossword puzzle every day at 95. She's a formidable woman. So don't think just because you're old, she'll tell you, I'm not old. Stop talking to me that way. Well, let's look at grief, because we thought we were going to have people go over it, right? We want to be scientific about it. We really think that's what we're doing. I'm going to show you some stuff that's very interesting. I want to just pique your interest a little bit. In a case control of 23 women who did terminations for anomalies and said, what really happens to these women when they have terminations? Well, at 2 months, they had major depression, and out of that, 22%, or 5 to 23, actually already sought psychiatric counseling. So that doesn't look like anybody's getting over anything. Well, that's only 2 months. Let's talk a little bit longer, right? Well, I love the Netherlands and I love Germany and I love other people because, again, they're ordinary. They keep great records. So they did another study in 2009. They did 147 women in the Netherlands. We did termination of pregnancy for anomalies. Okay, most of these lethal anomalies, maybe not all. MedSFLA, that sort of thing. Look at psychological outcomes at 4, 8, 16 months. At 4 months, 46% of these women still had pathological outcomes of post-traumatic stress. And 16 months, 21%. Now, you all know what post-traumatic stress is. You all know the definition of that. Intrusive dreams, nightmares, can't function. They can't be around children. They can't. They're crying all the time. They really can't function. So that's what we're seeing these ladies who've had terminations of pregnancy. Wanted pregnancies for anomalies. Okay, so they're not getting over it. Another very nice study, looking at grief and persistence as well. 253 women prior to 24 weeks gestation. Looking at the Netherlands again. Great data rate. 2 to 7 years after post-termination, it's still found up to 3% or 2.6% have pathologic grief, and 33 or 17% still suffer from post-traumatic stress. So it's not benign. You don't get over it. Okay? You don't get over terminating your pregnancy for an anomaly. So perhaps telling people what they should do may not be the right thing to do. Or at least they should know about this. Well, what about perhaps looking at spontaneous loss, which is sort of a way to look at it. A little bit different because it's a little different, but sort of a different cohort. So we looked at a couple of cohorts study looking at first trimester and 213 live births. At 6 months, there was increased risk for depression, right? And there was anxiety. About 1 year after a miscarriage and/or some of these were stillbirths, there was no difference in the psychological profile. So, different. Spontaneous, induced. I always like to show this because this is my daughter at 18 weeks. I'm a very proud father. This is my youngest child at 18 weeks, and she's actually giving me the thumbs up and suffering well. And I'll show you some other pictures of her now that she's a bigger embryo. Yeah. Finally, if we really believe in choices for patients, and we want to let parents be parents, which is what I want to do, I want to give people choices, real choices. 20% of people don't want to do an abortion or terminate no matter what. In fact, I'll show you some other data that says it's probably higher than that. It's 75 to 85% of people don't want to do termination of pregnancy. They want to take care of their children. They want to take care of their babies. Maternal mortality, we talked about that. We're worried about moms dying because of having babies go on. Well, if you look at abortions past about 16 to 20 weeks, which is kind of the time you do most of these terminations for anomalies, the data is very similar. If you believe maternal mortality data, which if you ever want to talk about that sometime, we can talk about that. But it's exactly the same. There's no difference. Okay, so you're not going to have more moms die because you let them be pregnant longer, right? This is my lovely first wife, Catherine, as I call her, and she allows me to do all those things. And that's why I always like to show pictures of her. What about hospice? I'm sure you've all heard a little bit about this, or maybe had somebody who's gone through hospice, or know about somebody who's gone through hospice, or has had a family member go through hospice. Very common. Cecily Saunders. Anybody know about Cecily Saunders at all? It's fascinating. And a wonderful English woman. Anybody know what Cecily was when she first started out in life? She was a social worker. Who then went to nursing school. And as a social worker, you know what she saw people doing? People who were dying were put in rooms and left alone to die. They weren't dead, but they were treated as they were dead. Right? I'm not dead yet, but yes, you are dead. You know what you're talking about, but you're not. And she said the real issue was withdrawal from the patient by the family and staff and physicians. If you talk to people that are going through hospice, they fear withdrawal more than they fear pain. They're not dead. They don't want to be treated like they're dead. That's what she did and helped us do. So what we're doing now is trying to provide a framework to help patients work through a fatal anomaly in a hospice concept. I'm going to ask another very important question, and this is going to sound terrible later. Anybody get my life alive here? Oh, I didn't think so. It's not a matter of if, is it? It's a matter of when. It's a matter of when, isn't it? I'm glad you didn't answer that, because I'm a little worried. We didn't have some of your psychology or psychiatry people up there. What about, why do we have to go to perinatal concept? Well, if you're anybody in peds, you have peds rotation that much? No? Well, I hope you don't have this fortune. I don't mean that in a bad way. I did mine on Tumor West. It was at the University of Iowa. We have one of the biggest oncology programs in the university at that time in Iowa, Michigan, Oklahoma gets it. But I spent 6 weeks treating tumors and cancers, right? And watching kids die. That was no fun, trust me. Closest to clinical depression I've been in my life. But that's where we got the neonatal, and learned the pediatric hospice concepts. But what do you do if the baby is not born yet? It's not there, right? There's no neonate there. So that doesn't really work, does it? Other concepts work, but that doesn't really work for us. Oh, isn't she cute? This is Penelope. This is Penelope. She has really bright red hair, she really does. And I saw her outside, she's just so cute. She's like 8 months old now. And the good part about being the parents having grandchildren, because you get to send them home, right? They're bad, you send them home. Well, so what is perinatal hospice? I call it the prenatal diagnosis of a terminally ill fetus in utero being in perinatal hospice as part of the continuation or the continuum of end-of-life care. Okay? So it's okay to take care of you, do that after born, like you do before you're born. Let's help these parents be parents. Let's give them a choice. Let's help them through this. Well, what are the characteristics of perinatal hospice? It's extremely comprehensive. It starts in my office when I diagnose it, or obstetrician's office when they diagnose it, or the family medicine doctor can do an ultrasound, or the sonographer comes in and says, Dr. Calhoun, I think we got an ancestry. I see that all the time. Last week, walk in, 14 weeks, ancestry. And that's supposed to be the happy, normal ultrasound. Not so happy and normal now. So, emotional needs of these patients, many of them are people of faith, so we try to meet the spiritual needs. Psychosocial, I have a very, very low income population. Some of them can't even make their appointments. How do I get them to see me? You gotta have that. Medical and obstetrical needs, which is what I do with my sonographers. I have residents. I have 3 residents a year, 12 here, 12 and 12 total. So for those who are interested in obstetrics and gynecology, I'm on your If you're interested in coming to the program, take a look at it, feel free. I'll leave contact information. Always glad to have students. Even 4th-year students rotation if you want. Come through the MFM and see how we do it. It's multidisciplinary. In other words, I involve nursing, sonographers, social services, chaplain services, my neonatologists, labor delivery nurses, neonatal nurses, all are involved in our process at some point in this time frame. We also involve other family members. If grandparents want to come in, other people want to come in, we're glad to have them talk to them. And it's coordinated. That's probably the most important part of this, is you don't stow population, but coordinate care. Well, how do we do this? We're going to talk about that in just a second.